language models, it is also important to critically examine the diagnostic and classificatory systems that we as mental health professionals use in our day-to-day practice. So I invite Professor Jain to deliver his talk on the topic Anglocentrism inherent to classificatory system, a fait accompli or a need to revise.
Thank you. Good afternoon. We just had a nice lunch, so I hope we all can pay attention. And for those who are not particularly interested, you can read the subscript to the talk. You don't need it all.
Yes.
So that's a long and short of the talk, which otherwise you'll have to listen to for an hour if you want to. The point has this comparison of, let's say, the classical models of medicine, which is Greek, Roman, the Hindu and the Buddhist, and the Islamic, which are the three major religions in this part of the world of Eurasia. They start with Hippocrates and Soranus and Galen in the Greek, and Charak Samhita and Bhela Samhita formalized some around 2000 years ago, and Reason and Ibn Sina around the first millennium, end of the first millennium. All three have humoral theories, which we are all familiar with, which is translated into the Sanskrit one as doshas. But all mental illness at least has a divine origin. It is a transgression. It's called the divine madness because only the gods above can interfere with the psyche of a human being, because psyche itself is a part of God, because as the Urdu word is synonymous of Khuda versus Khudai, the personhood is given to you by Khuda, and psyche is a manifestation, or the soul is something that is imparted by the God. And any disorder of the soul, therefore, have to be of divine origin. So this was a prevalent theory, right from Greeks to the Indian systems, and right down to Reza and Ibn Sina, which obviously had slightly more complicated versions of it. But whatever it is, the first lunatic asylums were established in Baghdad, and the teachers there were invariably Greco-Roman and Indian. Bhela's grandson, Bhela Samhita's grandson, was a faculty at Baghdad. The first medical textbooks in Islamic medicine were translations from Bhela Samhita. So there's a direct continuity of both Greek and Indian medical traditions in the Rezes. And what is listed below is various definitions of madness: alcohol-induced acute and chronic states, correlations with epilepsy, seasonal relapses, depression and mania, suicide, addiction, dementia, forgetfulness. All these syndromes were classified by the time of Hippocrates and Soranus being around 180. The Charak Samhita also, Unmada is the madness, intoxicants of various kinds, fear, anxiety, suspiciousness, posturing, dancing, singing, psychological states, acute and chronic forms, and poor prognosis of some people, and the fact that the mentally lose caste and thus a place in society was also well defined. So the basic premises of defining the symptoms and syndromes of madness was already in place 1,000 years ago. Under Islamic medicine, the disorder of the soul became very, very important because the ruh was a specific instrument of the God. And the causes, again, could be intoxicants such as love itself, or of books, or of substances. And they also had a peculiar madness caused by preoccupation with numbers. Now, this is a very interesting concept in Islamic medicine. So it is a transition between the Indian mathematics and European mathematics. So if you try to convince, I'm sure many of you would have had the same problem. How do you conceptualize zero? It's not a physical entity. Yeah. Most languages to do with objective reality. Zero does not have an objective reality. You're now giving an unreal substance an objective existence. And preoccupation with it was enough to drive people mad. So the Arabians recognized this preoccupation with Indian numbers as a form of madness, which you see all the way down now. You're talking about people who write algebra and code and things like that. And in all three heretical sects, whether it was the Bhakti sects of the second millennium, whether right from Akka Mahadevi to Meera to Kabir, all of them had so-called episodes of madness, as did, in a particularly cynical way, no religion would have existed if it was not for psychiatry. Most of the godmen whether it's Christ or the prophet, or they derive their popular following because they can revert blindness, hysterical blindness. They can wake people from stupor, catatonic stupor. They can make the lame walk, hysterical fits, etc., etc. So it was only by addressing psychiatric morbidity that religion could survive. And so madness has always been, and these exchanges between Greece, between Europe, India, and the Middle East had a constant change, and these were all somewhat similar. And this was obviously overturned by what we were discussing earlier of the Industrial Revolution and the wealth of reason and logic. So this is a kind of a parody of Chinese knowledge. It's called the Celestial Emporium of Benevolent Knowledge, an illustrated taxonomy by George Louis Borges, who got the Nobel Prize sometime in the 30s for literature. He classified animals as these: those that belong to the emperor, embalmed ones; those that are trained, suckling pigs; mermaids, fabulous ones; stray dogs that are included in this classification; those that tremble as if they were mad; innumerable ones; those down with a fine camel hairbrush, etc. Those that have just broken the flower vase like your pet cat; and those that at a distance resemble flies. Technically, it is accurate. If you think of animals, this is completely inaccurate. But this was a kind of story which he pointed out that the limits of which Aristotelian and Linnean thought. Linnaeus, famously, one of the first classifications that he applied after botany was to madness. So that whole idea that madness, all disease, follows a genus, a phylum, a genus, and families is something that is inbuilt from the time of Linnaeus. So whether schizoaffective disorder is a part of schizophrenias or mood disorders, or are they both part of psychosis, or they're part of brain disease, is debated. So this phylum, genera and families has been debated from then. But what Borges was trying to point out, along with Foucault, is that all this is necessarily arbitrary. It represents a snapshot of contemporary thought. It does not necessarily have an inherent validity. So this is a kind of, why do we need to classify? This is a classical statement by Confucius as to why one must use the correct words for the correct things. And as you can read, when the names of things are incorrect, speech does not sound. When speech does not sound reasonable, things are not done properly. When things are not done properly, society is harmed. Structural society is harmed, punishments don't fit the crime, and punishments don't fit the crime, and people don't know what to do. And if you substitute psychiatry for that, and that is where all the symptoms of psychiatry come in. When names of things are not correct, neologisms and paraphasia, speech does not sound reasonable, level of discourse. When speech does not sound reasonable, things are not done properly, etc. And things are not done properly, the structure of the psyche is harmed by psychopathology and social disability. And when the psyche is harmed, the treatments don't fit the crimes. So whether you need to send psychotherapy or drugs, we often get confused, and treatments do not fit the diseases. The psychiatrists don't know what to do. So whatever be the errors of the whole system, arbitrariness, we still need to know how to call things by the correct names. Now, this has become possible only in the last few hundred years for two simple things. Because as psychiatrists, we are basically concerned with this phenomena. Why do people go mad and how can we help? That's the basic premise that we have. And for that, the assumption, the axioms are that psychiatry is a branch of medicine, and medicine is based on the principles of biological science. There is no other axiom that we need to follow. There can be no other explanation other than that of science and observation. And therefore scientific progress and material processes should be enough to explain the occurrence of disease, whether it's at the level of the electron or a synapse or a circuit or an organ or the way whole organisms behave with each other. There are still patterns and logic to be observed which can explain the occurrence of disease. We need not fall back on a mystical cause. That's the basic premise. And for that, the secularization of human existence is essential. Now, this is not secularization as we mean in politics, but it's just that before Vesalius and Harvey and the dissection of the body, the working of the interior of the body was as mysterious as anybody else. Once you dissected the body and you realize that the heart beats and is a hydraulic wave which is traveling, making your pulse, full stop. So you don't need to think of a vital force or a elan vital or some kind of energy going through you. It is just a pump, just like a tap. There's nothing more to it. All cardiologists are basically plumbers. That's the point. But the point is that the heart could be robbed of its mysticism. After all, it was only in, I think, my Madhava in 1300 AD, which located the psyche in the brain. Before that, it was all assumed to be in the heart or the liver. The fact that the brain is the root of your intelligence is very recent, just about 500-700 years ago. Before that, it was assumed that your heart is actually the source of your psyche, which is why Dil Ka Dard and Dard Dil and all that. But it was in the Indian philosophical terms, it was only Madhava in sometime 1300 and 1400, from what I read, who said that it's the brain which is important. So this whole idea that these organs exist, that they have very specific functions, and that they can look at, that you can understand their functioning in a particular kind of way. Now, this, of course, was positioned even more dramatically in the middle of the 20th century by Erwin Schrödinger, the famous Schrödinger's cat. And you can paraphrase Schrödinger's cat as being in and out of the black box as the psyche. Is the psyche in the brain, or is the psyche outside of your brain? The same thing, same issue as Schrödinger's cat. So does the mind actually have matter, and why it matters? Does the material process of the brain create the mind? And is the mind reducible to material processes, which lies at the fundamental issue of psychiatry? But because of this dilemma, psychiatry is an abstract branch of medicine, and it is not confined to just neurobiology. Now, the reason why this particular topic comes up these are particular papers from around 150, 175 years ago. This is one by Pandurang, just an Indian name, and colleagues, Indian Medical Gazette, 1869, writing a paper on hysteria. This is the point around the time Freud is born. Okay, so well before Freud has even come to adulthood, there are Indian doctors writing on hysteria. Okay, for us to assume that Freud's notions are somehow European is therefore quite incorrect, because you have Indian doctor called Pandurang writing a whole paper on the nature of hysteria in 1869. There's a girl named Haribai, aged 12 years, who had unremitting hiccups, pupils are dilated, abdomen soft, spasmodic twitching, and etc., etc. I haven't put the whole history, but she's patient at about 8:30 a.m. was engaged in heaping up cow dung and saw a snake, and then went into this fit. Now you can claim it as a fear response. If you're Freudian, you can call off phallic impulses and the symbolism of the snake and the phallus. You can do all kinds of interpretation. But the fact remains that this young girl, is successfully diagnosed and treated for hysteria as a psychological response to a frightening influence using Western terminology by 1869. This is even earlier, 1867, Ramchandar Mitter, who is in Arra, which is in Bihar. A case of mania successfully treated, acute onset in the middle of the night 4 days ago. 14-year-old girl, already married, brought in by the mother-in-law, keeps singing day and night, does not sleep. And the notes are very clear: no family history, no physical stresses, no fight with husband, not pregnant. So all the common causes of mania are ruled out as per the knowledge of 19th century Western medicine. All these are factors listed already in science by then. There should be a family history, there should be no physical stressors like recent illness, fever, no interpersonal stressors like fight with the husband, and not pregnant. So all this formalization that onset of madness may have these features, a family history, fever, etc., are already documented. And this doctor, Ramchandar Mitter, is already familiar with that. And the patients are brought very early to the clinic, and therefore she recovers within 2 weeks. I haven't put the rest of the notes, but it's a detailed note, and 2 weeks later, she is discharged. She's blistered in the head several times. Okay, now contrary to popular belief, blistering is not an Indian folk remedy. It is a British folk remedy. And everybody and all the temples around which blister people have actually learned it from the British. There's no history of blistering in India. So blistering is a British remedy, folk remedy, which we have now incorporated and made it historical. That it is historical treatment in India, which is completely wrong. She is blistered and she recovers. Then there is even more elaborate is hypnotism. Now, hypnotism is a very important issue because mesmerism, as you know, was formulated by Anton Mesmer sometime in the end of the 18th century, for which he got expelled from the French Academy of Sciences because of belief in mesmerism. Mesmerism does not obey the laws of chemistry and physics and mathematics. The committee was headed by Lavoisier, Benjamin Franklin, and Guillotin. These three people decided that what mesmerism is proposing is non-scientific and even of the few people to be expelled from the Academy of Sciences. He went off to Germany, went on with his career. Of course, Lavoisier got a head cut off by Guillotin. So committees have a way of turning on into each other. So whenever you go to an IRB, be sure of that. Sooner or later, they will fight. Anyway, so Lavoisier lost his head. But anyway, the point that Mesmer made was very clear. Now, mesmerism allowed one person's psyche to influence another. And people who have worked on the history of mesmerism point out that is a radical difference. Before that, the only people who could influence your thinking was either the priest or the feudal lords. There were no individuals before that. You were citizens. You were slaves or citizens. Citizens were under the tutelage of they either had to obey the church or the state. Mesmerism said that you can communicate directly from one mind to the other without either feudalism or riches or power come into the picture. So it's a very radical thought as a social construct. And therefore, hypnotism spread widely. There was a mesmeric clinic set up in Calcutta by a German doctor, very famous in Sukia Street. They operated, I think, 800 cases under the pre-anesthesia days. By hypnotizing, they did surgeries, they did hydrocele operations, and you can see all the details. But what is important is that they're doing hypnotism in India. There's a British doctor who is doing hypnotism to an Indian patient, which means the psyche of the both are on the same equal plane. The first thing that happened after 1857 was that mesmerism was abolished because the British administration could no longer have this fact public that the mind of a British and an Indian can actually communicate to each other. You have to be superior and inferior. So equality was gone. Now, psychotherapy can occur only when there's equality. There should not be any superior inferior dynamics. And for that very reason, it was banned. But the fact that a British doctor can do therapy through English to Urdu to Pashto means that there is a certain communication of the mental space between the European and the Indian and the patients. So there is fundamentally no difference. Okay, so these are the details of that hysteria case, the theoretical amounts. So unlike Briquet, which is the famous Briquet's neurosis of 1855, he does not see hysteria purely as a brain disorder, nor like Charcot see it related to sexuality, which is what inspired Freud. Okay, which considered the possibility of snakes symbolizing repressed sexuality. He sees it mainly as a true morbid condition or disease condition of the corpus striatum, which more generally happens to be the case. So Mr. Pandurang thinks of an organic, neurological, physiological basis for his hysteria, which is much different from the social consideration of Charcot and definitely different from the libidinal theory of Charcot. So the point being that these very different ideas of neurobiological basis, psychodynamic and social origins are all being worked on in the mind of the Dr. Pandurang here. So there is an easy familiarity with all contrary ideas of Western science as applied to India, and he chooses what he thinks is the best, the organic ideology of hysteria. Okay. So there is an awareness and acceptance of the interior of the mind, both Indian and European. Now, this is very, very important to understand. Even when you go through the notes of the annual hospital, of the mental hospitals, the debate is about we have acute and chronic mania, acute and chronic dementias, visible excitement, other by depression. There are painful sentiments. There's sometimes propensity to suicide and homicidal impulses, and which complicates every form of derangement of mind. It is always dependent on the delusions, etc. They're very elaborate explanations. Whether schizophrenia and schizoaffective disorder, they should be congruent or separate distinct categories. And this is all in the 19th century. So the fact that these ideas, which we think are very contemporary psychiatry, were there almost 150 years ago, is quite important. Even more startling is the way Western technology intrudes into Indian, so-called Indian thinking. MacLeod writes a whole critique of phrenology. And phrenology, as you know, was this whole idea of assessing a person's personality by the shape of the skull. So it forms a necessary connection with the brain and the mind. And McNamara does a whole sort of measures. Mentally ill and lunatics have a smaller brain size than normal people, much like we now talk of cortical atrophy or cortical thinning in people with chronic mental illness. So the basic premises of this are being at least speculated on by the 19th century. And of course, in Bangalore itself, Smith thought that insanity was correlated with softening of the brain, because for every patient who died in the psychiatric wards had to have an autopsy done. So they obviously were aware of the organic etiology. These ideas also intrude into the way we think of so-called traditional medicine. So these ideas of phrenology are now incorporated into this tantric notion of the nadi's structure of the human mind. This does not exist before Western neuroanatomy comes in. This Western neuroanatomical detail is incorporated into this so-called traditional method, which is then given a historic past as being older than the first. Mm-hmm. But actually it is just adaptation of this into these prints, as this paper points out. So the ideas, the functions of the brain are then metaphorically linked to the 1,000-petal lotus chakra of the head in tantric ideology. And just like the brain in phrenology has a particular set of functions, those functions are given an almost equivalent structure in the 1,000 lotus structure of the human mind. And an effort is made to make the two congruent. The fact that people are trying to achieve a congruence between so-called traditional ways of looking at the brain and mind, between the emerging Western technology-driven approaches and the Indian philosophical approaches, means that there is a need to synthesize the two approaches, that they should not be seen in opposition to each other. Now, this had obviously the other versions also. So a number of writers in the 19th century felt that mental illness is increasing all over the world with progress in civilization. This was as true of England, as America, as of India. So as societies become more complex, the rates of the mentally ill, people in the mental hospital become more and more. And they assume it is because of civilization, and there's enough criticism of all those things. We don't need to concern ourselves about that. The important statement was from Weiss. T.A. Weiss, who I mentioned earlier, is the doctor and a Sanskrit, professor of, he's well familiar with Sanskrit enough to translate 6 Sanskrit textbooks of medicine into English. He knows enough Sanskrit for that. And he's also the superintendent of the asylum in Dhaka, in Bengal, no, in Bangladesh. So he says insanity is rare in a country where the mental faculties are so less cultivated. And the Hindus, by this he doesn't mean the religious Hindus, but everybody who lives in India, are perhaps in a lower state of mental development than even the rudest savages. But this statement, as I mentioned, is criticized very strongly by academic psychiatrists in London. And Weiss, this is the only book he ever writes, and then and on psychiatry that he ever writes. But this idea continues because the point that they make, which they observe, is that most of the people who come to mental hospitals are in a very bad state of health. They have lots of infectious disease, they have malnutrition, they have fevers, they have head injuries, they have been beaten. So they said mental illness here arises more often from physical causes. Plus there are high rates of ganja and alcohol. So they say it arises more from physical causes rather than so-called moral causes, which is as they observe. But then they also make the opposite judgment, which is a bit strange, that Indian natives are little prone to emotional excitement, but at the same time, the requirements necessary to impart contentment to their lives are few and simple. You don't have to worry about your next grant. You don't have to worry about your next promotion. If you're happy if the cows come home, and that's good enough. One cow doesn't come home, a tiger's taken it away. Probably that's the most harmful thing that happened to your lifetime. It was that difference between cultural life in England and India that they noticed was quite stark. By this time, the British had already had a mad king, so they were quite aware of all that. This was amplified in the early 20th century or middle 20th century by a person called Carruthers. Now, this is a very peculiar problem of modern day psychiatry, that we see India as India, but India was part of the empire. The empire contained Africa, Australia, large parts of North America, and India. The same forms are filled for every country. Exactly the same form for recording history. So you can technically compare a patient in Canada versus India versus South Africa versus Kenya versus Nigeria versus Australia at the same year, anywhere. But the hospitals in Africa were started in the 20th century when they finally could conquer Africa. The ones in India were started in the 18th century. So there's a huge difference in the way they perceive India. And America and Canada and Australia, of course, they were starting them brand new. There was no ancient established civilization with structures that they could build on. So the African mind was therefore much more. The idea of African society was developed at the height of racism, when Darwin's social Darwinism and race theories had become particularly apparent. And in Europe itself, Nazism and color theories were very rampant. So for Carruthers, it's from that background when he talks about Africa having low rates of depression because they lack a prefrontal cortex to develop notions of guilt and shame and sadness. So therefore, Africans are basically lobotomized Europeans. It has been pointed out that he was not even a psychiatrist. He had no professional training in psychiatry at all. And unlike the doctors who were sent to India, who all said that they are much the same, he was not Oxbridge. All the Cambridge and Oxford doctors would come to India. It was the other colleges should be sent to Africa. So he's considered not very bright in the head. But because of the mid-century politics, he became the head of the WHO inquiry into the African mind. And this idea of Africa having a less civilized mind became perpetuated in a lot of colonial psychiatry. And refuting it by Frantz Fanon and all the other African colonial psychiatry movements became an element of choice. Whether the same thing ever applied to India, we actually do not know. No British psychiatrist ever talks about Indian psychological problems being different from that of the patient that they see in UK itself. Not a single psychiatrist I've been able to see in their notes, except for these very global kind of judgments, and the epidemiology of psychiatry. But in the actual patients who are coming to the mental hospital, they don't notice any change. But similar work is attempted in the middle of the century in India. Berkeley Hill, who was the head of CIP Ranchi, is asked to do an inquiry into the psychological state of terrorists, which is basically members of the Congress party. Okay, freedom fighters. And he very resolutely said they're perfectly normal. There's nothing wrong with them. They just want independence, autonomy, just like we want, just like any average citizen wants in England. And it doesn't go very far. He almost gets suspended. There's another petition made for him suspending him because they already threatened him suspension for some other ideas. And this adds another because he says there's nothing wrong with all this. They're perfectly right in asking for freedom. And this is after the fact that he's been beaten up himself. And sometime in one of those violent agitations in Bihar for freedom, they beat him up for being an Englishman. And he says, I'm not going anywhere. I built this hospital. I've served the people, and I think I have as much reason to be here as any of you jokers with lathis. So he refuses. Anyway, so he sees no difference between his responses and the average Indian response. The army accounts of the psychiatrists who have served in the First World War and the Second World War notice a particular phenomenon called trench back. Now, trench back is a psychosomatic illness of low back pain caused by, at that time, when you're standing in a trench and the shell comes and you get buried under the soil. And then by the time you're extricated, you're obviously very frightened, and then you complain of trench back and you can't go back. The issue is that the British psychiatrists, for the British patients, call it hysteria. For the Indians, they start doing X-rays. because Indians don't have a psyche. They have to have something wrong with their bones. Okay. Whereas the Westerners have a psyche and therefore they have shell shock. Indians have low back pain. So the somatization is actually reversed.
It's actually a reverse.
Reverse. So now when we talk of somatization, we are actually adopting the British colonial attitude for somatization. So these ideas have a way of going round and round in circles. That's the whole point, that this idea that why is shell shock in Indians cause back pain, whereas in white soldiers, this shell shock and anxiety neurosis has a very different outcome. Norman Pacheco, who's also a deputy medical student of Ranchi and the first Indian, he writes the first textbook of psychiatry written by an Indian. He's from Richmond town, so he's Indian. And Kirpal Singh on wartime neurosis again point out how Indian soldiers have very different responses to battle time stress. So this is a time when cultural difference between Indian soldiers and European soldiers start coming up in the context of the First and Second World War. And this is extended by Nandi et al. In the epidemiology of depression in tribals versus others. And R.L. Kapoor, who was head of Department of Psychiatry here, who did a study on terrorists of various kinds, I think partly on Maoists and partly on Kashmir, where he again pointed out that there's no difference. There's no psychiatric illness driving these movements. But the differences by geography and region in India and prevalence of psychiatric syndromes was often commented. The most elaborate one was a paper, I just joined NIMHANS and there was a paper by Venko Rao in volume number 1 of the first edition, in the first issue of the Indian Journal of Psychological Medicine. It was a 14-page article, enormous, on depression across the world. And he compared depression in India to Papua New Guinea, to Nigeria, to other tribal populations, etc., etc. And then within India. So he gave rise to very amusing kind of debates, which exercised all of us during our MD exams. And why are delusions of guilt so uncommon in India? Okay. So their idea was that because in monotheistic religions, you actually have a notion of sin.
It's easier to sin.
Yeah. Easier to sin. Where Hindu with 1,000 gods is easier to forgive. So instead of guilt, you have paap. Paap ka prayashit kar sakte ho. But guilt is, so these kinds of differences. And why it is less in North India versus South India, because North India, we know, are uncouth and unmannered. So obviously, depressive feelings are more in the South. So all these, that is written by Venko Rao without any trace of. So people like Vic then had to answer that. So all kinds of, we had to learn all these, we had to read all these papers, so which is why it's a painful memory. But the difference by geography and region of depression was guided as much by ethnicity and biases of the researchers within India as it was done between Europe and others. That's the point. That these biases are inherent to the nature of these definitions, because your definitions are context dependent. And there's nothing called, so Anglo-Saxon or, NIMHANS versus, Al-Azhar, where I studied my psychiatry in the first few months, I had to unlearn everything I learned in Delhi. Almost everything, except how to give haloperidol. Everything else had to be unlearned, but the rules were very different in NIMHANS. So what is it that we, what is it that we understand now? The theories that were prevalent in the West were applied to the mentally ill in the 19th century. There are other studies which should look at urine changes in melancholia. Bazaar medicines are regularly used, blistering, morphia, cannabis. All these are overlapping with traditional treatments of medicine in India for the previous 1,000 years. So there's nothing dramatically different that happens there. By mid-19th century, when Indian doctors trained in Western medicine emerged, they used Western concepts readily and incorporate all the prevailing conditions around them. There's another very interesting paper around the 1870s, where a young woman has some psychological issues with depression, and the doctor who's treating her, who is not a Sikh, from some other part of India, advises her to use the Guru Granth Sahib as a kind of therapy. Okay, now this is astonishing because the contemporary standards, very few plenary lectures of Indian Psychiatric Society, which often talk of religion and psychotherapy, I have not seen a single lecture by a person of one religion talking about another religion. I've not, it's always their own religion, whether the Gita or the Quran or the Bible, or it's always by a psychiatrist who happens to be of that religion. Whereas in the 1870s, a psychiatrist from a different religion would advocate the use of Guru Granth Sahib as psychotherapy. So these ideas of that your therapy has to suit the patient's cultural milieu, not your cultural milieu, was also well established. Okay. Western doctors, of course, saw no difference between the Western native mind. By the middle of the 20th century, these become very obvious as a fallout from Nazism and all the other things that are going on in the 20th century. And by the late 20th century, we have an asymmetry of knowledge and science and technology. So because we do not have this is again a kind of tangential input. But for example, in doing genetics research, we were often told that you cannot do research in genetics India because Indian population is so diverse and so fragmented that your patients and controls can never match. Because your patients come from very diverse areas and your controls are very different. But till you could show that the genetic variation between Kashmir and Kanyakumari is only marginally more than that between Scandinavia and Spain, that we are as homogeneous as Europeans are, almost as homogeneous. It does not matter whether you're from Kanyakumari or Kashmir. You're essentially overwhelmingly as similar as a Spaniard and a Scandinavian. Whereas we are willing to see the whole of Europe as one lot. In India, we keep thinking of being utterly different cultures. The Kashmir and Tamil Nadu cannot possibly be the same. It's a very erroneous idea. So the politics of conflicting race, heredity, and biology has confused our understanding of the unitary nature of psychiatry. Too much preoccupation with all these has given rise to efforts to make diagnosis or application of medical technology or medical awareness intensely local. The problem is that intensely local is in a sense enforced by the World Health Organization. So why is the World Health Organization telling you to be local? They are the World Organization. Why? And there's an anachronism there which I never understand. So this idea that there should be an automatic dichotomy between the Western systems of science and technology and native systems, in a sense, perpetuates this asymmetry. The fact, as we were discussing earlier, for every other discipline of medicine, whether it's cardiology or orthopedics, you want the latest stents, you want the latest scans, you want the best Western technology that you can have. But for issues of the mind, you're somehow suspicious of Western ideas. Why that is so, I have no idea. Because for every other aspect of our life, we see ourselves as equal partners, whether it's designing missiles or designing airplanes or designing software, we want to be at par. But when it comes to psyche, we want to say we are on a different table entirely. So this in a way inhibits the growth of psychiatry. Now, therefore, this insistence on a historical antiquity and a historical difference, which bypasses the current sameness, is very disingenuous. Which is why when one should assume that whatever the notions in psychiatric classification have grown, and as mental health professionals, we know that they've grown incrementally with lots of checks and balances and corrections. Like anything, nothing is perfect. But they have grown in a systematic application of observation, validation, refutation over 200 years from the time of Kraepelin. And it's really, you can't even call it Anglo-Saxon psychiatry, because Kraepelin's textbook, which arose out of his experience in 3 mental hospitals, and now in Estonia, then in Munich, and then lastly in Heidelberg, that is the only textbook of psychiatry which is translated into Korean and Japanese and Russian. Okay, now whatever be your other differences in your government or your societies, you basically use Kraepelinian models of classification. And they have proved effective enough and useful enough for countries as diverse as China, North Korea, Moscow, India, Japan, America to adopt them. To say that they are somehow, it's an Anglocentric imposition, therefore seems a bit unusual. Because it is part of the prevalent It's like saying Newton's laws are Anglocentric. I mean, it wouldn't make sense. Perhaps it is not as extreme as that. There need to be some nuances for local understanding. But those are, let's say, minor cogs in a very large wheel. Most of the time it works quite well. So what is it that we can think of? As you keep mentioning, psychiatry has a long past. Everybody, all societies and historical accounts know madness. There's a short history as a discipline is only 150 years old or 200 odd years old. But that's about the same time as cardiology and orthopedics. Around all these disciplines arose out 20 years ago. But when you get into the future, we have to invent perhaps a very new definition of mental illness, which combines all the stuff that we are talking about, combines neurobiology and network behavior and trait definitions into a new way of looking at the varieties or neurodiversity or the varieties of human existence. Because one thing is amply clear in any work, all of us look different, but all of us have roughly the same kind of schizophrenia, or the same kind of blood pressure, or the same kind of manic episodes. So illness produces a kind of homogeneity of experience which far surpasses that of individual cultural differences. So how do we identify that remains the question. So what are the new ways that we can overcome or go past these old classifications of race and culture and et cetera, and actually be independent of our history and plan for the future? And how do we think psychiatric definitions will work in the future rather than quibbling endlessly about the past? And that too a very short past. We've been independent for longer than we were colonized. So it's high time we gave that up. It's now 75 years, isn't it? Or 80 years? 75.
76 running, yeah.
Yeah, and 1857 to 1947 is about 90 years. So it's almost the same time.
No, I think it was 1757.
That was only Placid, that was only Bengal, not the rest of India.
That's why I have a different calculation.
That's true only of Bengal.
Right.
Thank you so much, sir. Thank you so much for that wonderful lecture. I think there might be a few questions.
I'd like to start it off.
Please.
Why, I mean, based on your presentation and your, the subscript on the title slide, why do we have this chapters after chapters on transcultural psychiatry? Why does DSM-5 says cultural formulation is essential?
Right. So, if you'll excuse me for blowing my own horn in that sense, a couple of months ago, I did a seminar, not a seminar, a kind of discussion for the Royal College of Psychiatry on this topic. Now, the fact remains that India produces around 1,000 psychiatrists a year. There are about 20,000 psychiatrists in India and 10,000, about 6,000 in UK and another 6,000 or 7,000 in Australia, New Zealand, Canada combined. So about 12,000 psychiatrists from India work in other cultures. So I think the better way would be, how do transcultural psychiatrists work? Because Indians are the single largest group of psychiatrists who work across cultures. We are actually the only psychiatrist from South Asia migrate so much. So if anything, it's South Asian doctors who should be able to tell you what transcultural psychiatry means. No other person has the intellectual or experiential validity to say I have worked across cultures, other than their own preconceived notion of what a culture should look like. The only people who have lived in one culture and worked in another culture are Indian doctors, or South Asian doctors. So transcultural psychiatry should be turned on its head. It should be transcultural psychiatrists. Because there's no such thing as transcultural psychiatry. There are only transcultural psychiatrists. Now that, unless it is written by an Indian, by a South Asian or a Middle Eastern psychiatrist, nothing else has a validity. I mean, it's an extreme position. So this is the point of argument. This is where the argument.
No, but then that doesn't answer my question. So is the importance misplaced?
No,
is there a lot of
the importance is not misplaced. The issue is that Because the mind is an abstract entity, and because the functioning of the mind is dependent not just on the biological antecedents of brain biology, but also the psychological and social inputs that make the mind a dynamic process. Therefore, to understand the social and the personal dynamics that affect a person in that situation that they are living is very important. Now, whether a person's life is stuck to a cultural basis of origin, it's like the history we take. There's a family of origin and there's a family of procreation. Frankly speaking, if you ask me, if you ask any one of us, the culture that we grew up in is not the culture we live by. Okay. So therefore, I would be quite astonished if somebody asked me to conform to a role of what an ideal notion of Punjabi culture in Lahore would have been for the rest of my existence. Now, to fossilize the notion of culture into a static entity and assume it as a fixed entity is not correct. So cultures are as dynamic as the human body is. So the issues faced by a migrant worker, again, practical experience. Yesterday, I was seeing a case whose 45-year-old Bengali housemaid who was moved here 25 years ago, has paid several bribes to get an Aadhaar card, this card, that card. She never wants to go back to Bengal ever again in her life. Okay, ever. She's had two daughters who run off and gone back to Bengal. She has no intention of going back to Bengal. She's quite happy here. Although she has no friends, no family, no direct relatives. Okay, she's living a very solitary life, is intensely depressed because of that. But that person's problem is to be understood by her Bengaliness or by her isolation in Bangalore. Which culture should I refer her to? Okay, so the idea that these cultures are fixed, that there's something called a tribal culture or a geographically confined culture is inherently dangerous because it gives rise to us and them theory, which gives rise to issues like partition, which we've also written on. So this idea that what is applicable in Lahore should not be applicable to Delhi is the root of half the problem. When you could not treat patients in a mental hospital based on the religion, it's part of the problem. So when Israel was created in 1948, the first act was to transfer Jewish patients from London to Israel. Now that's a very funny idea. That a person who lived in London, gone mad in London, now has to be transferred to a new country called Israel, mainly because he's Jewish. Now that's a madness of the world, not of the patient. So you can't conflate. Now, would you say that because he's Jewish, he should be looked after only in a country called Israel, which you created 2 weeks ago? Is he better answer? Is his needs better looked after by a Jewish physician, where all his life he's lived in Maudsley Hospital, being seen by Indian doctors, probably Govind Swami when he was a resident there? So it's I think the whole idea of cultural causation is overstated. It is overstated, and see, even in the 50s, there was this severe criticism that anthropology and sociology are becoming handmaidens of a colonial gaze. It is always there are people who are never at the table, but always on the table. So other societies can be carved. Anybody who's traveled abroad will know that New Yorkers look down on Bostonians, and Bostonians look down on Chicago. And Chicagoans think LA is a weird country. But these are minor differences. You cannot. It would be as would you go and say that I want to study the outcome of schizophrenia in New York versus Boston. They're the two different cultures. You would be laughed out.
It also about the inquiry. So basically, transcultural is about where the inquiry is coming from. So this entire thing of an ethic model versus an ethic model. It's about who's asking the question.
Yeah.
Right. Rather than the fact that a culture creates a specific psychopathology.
Yeah.
I mean, although we were taught to believe that there's Piblocto, there's this and that and whatever, but in the end, it is about who's asking the question.
Yeah.
And if you're asking the question from thing of having grown up in that environment, then it is one thing. If you are asking the question from another environment and you are coming, obviously it is Archean and science fiction, not psychopathology.
So that's precisely at the heart of the problem. What the question is, a sentient agent whatever that person be, who has studied, say, DSM or ICT, put in a culture, will that agent require a special course in the culture of that particular situation in which we have put him or her or whatever it before they can be called a competent psychiatrist? That's my question.
So let me turn it around. I think the problem is actually with the DSM or the thing, because it's like the Bible. You created a Bible which has to be delivered in toto.
There has to be a
into
scientific
everybody,
method.
and it has to be translated into 14 different languages. You cannot change the Bible.
No, he's saying that the Bible is guaranteeing the scientific method.
No, I never said that. I said it reflects the issues and the attitudes of that time. It is not a permanent document. It's not Newton's law.
Whereas the Bible is a permanent document.
Okay. But then for the time being, I mean, till we have a new Bible written, this is the Bible we have.
5A, 5C, 5D. No, but that's not the point. The point is that after a while it becomes pointless.
No, I mean, I'm sorry. It's something that I've always had a problem with. People always have laughed at me for this. But for example, the rules, etc., which codify a diagnosis are ridiculous. You actually sat and seen people sit in a room and make them up.
Then
It is concocted, it's as delusional as they come.
Then the results of NMHF are in question.
I'll give you an example, ADHD. Okay, the criteria for ADHD miss out most of the important points of ADHD. Okay, and so when you're teaching somebody and you're teaching a disease construct based on some of the polythetic rules, then you're missing the wood for the trees. Then you're not training the person to understand the crux of the problem. You're just getting the person to understand these rules. And so that person will try and then retrofit it into whichever culture he goes and say, oh, it's so difficult.
It's a measurement problem.
It's a
So
measurement
we
problem.
have to define before we start measuring.
Absolutely. So it is a problem of the seer rather than, a problem itself.
We need a secular measurement, no?
Well, it's not, see, that's right.
Possible
It's not in psychiatry.
That's what I'm saying. So psychiatry is a special then. Probably we.
It's an abstract science. The rules will be abstract. You have to live with that ambiguity. You cannot enforce a sphygmomanometer on psychiatry. You will never have a barometer scale.
And yet we tried to do it by doing these
All these ratings here.
arguments, which were created by people we know, and we've seen how they went about doing it. And what was worse was when the questionnaires came in, the structured questionnaires, etc., which was even more straitjacketing, because we believed that it brought scientific method into something which was intrinsically not to be understood through that method.
Okay, I think that was a long leap that we took, because he started his presentation with the scientific method, and I think at the end we are saying it's we must not study with the scientific
No,
method.
this does not fit into the scientific method.
What is this?
The way we try to categorize, mental illness.
These are approximations.
These are approximations.
So just like you could make a building, after all, vernier calipers are new. But the Taj Mahal was built before that.
Well before that.
And it was built with great precision. So obviously there are ways which approximations can be made to work well. Now, the fact remains that we have forgotten the mathematics of building Bijapur or Taj Mahal ourselves now. We cannot make a straight wall, leave alone a building. But that's a matter of how these skills of approximation and measurements are rooted in your culture. After all, if a routine mason could build a perfect wall then, why can't they do it now? The measurements have remained the same. The wall has remained the same. It's just that we build crooked walls now instead of a straight wall. So the issue is the scientific method applies equally well to the buildings as it does to day-to-day life. So all physical structures also obey the same laws of approximation. And it's made, see, at this point in time, for many parts of medicine, precision is a chimera. So what we learned as grading of cancers was obsolete by the time we became faculty. By now it is completely different. But there's still a correlation with stage one, stage two, stage three, four. The kinds of somatic mosaicism you see in stage 1, 2, 3, 4, you are building up on that history. Now, if I decided that each new model needs to throw away the ladder on which we have climbed, it would be a very different space. All I'm saying is that this is a temporary ladder. To throw it away at this point would be, and that's why what the future holds is very different, could be very different. But there's no point in throwing away a ladder based upon 19th century preoccupations with race and politics. We need to move away from that kind of preoccupation and think of diagnosis as being a working model. That's all. But one cannot claim any scientific validity to it in the strict scientific sense.
I'd like to flip that question what he asked. Okay.
Sorry, I can't see behind, sorry.
Yeah. We are looking at the dominant narrative which gets better. You were talking about the blisters. So these were narratives which we have not understood on a popular scale. Suppose many of these classifications, alternate classifications, were also equally popular. Would that constitute some cultural?
Yes, I see. That's why I made that list. Now, the correlation between the identification of preoccupation with addictive substances or love or numbers are equally liable to cause madness. So the fact of addiction or preoccupation, a few themes in your life, is picked up 1,000 years ago. That's the same as it is now. But the causality of it is very different. The causality of it is by genes then, and is by dopamine now. Is there a metaphorical difference between genes and dopamine? I have no idea. None of us have seen a dopamine molecule. None of us have seen a gene.
But when it comes to teaching, if you say this is put into the textbooks, put into the teaching,
See, text.
and where would you get that alternative?
See, this is a peculiar preoccupation that you find in India. That somehow we try to make every book into a Veda. Like this is a text. This is a holy text. Each version is only valid to the next edition. It is not inviolate. So
Next exam. Next exam.
exactly.
What he's saying is that knowledge is not immutable.
Yeah.
It's immutable.
It's not.
Yeah.
So we try to think of every book as being representative of the holy Vedas, that they are fixed in stone, that this is the way things have always been and always shall be. Actual knowledge is not like that. So these keep changing. The CTP from volume 1, from the first edition or second edition, which I think second edition of the first one I handled. Now it is in God knows what edition now.
Level 12.
I was an MBBS.
PGP current edition 12th or 13th?
11th, I think.
11th.
So when I lived through 10 editions of it.
The green book is 12th, yeah. Yeah, we got that.
That's for the whole of science. So why don't we expect the same thing to be in psychiatry? It was false then, it is true now. We could think of
How could I become the same?
No, anyhow, it's the same group which would be discussing related matters. So
no come.
we could do a hot swap too, because the camera can only focus on a certain number of seats, and you are holding this panel.
I think we have a couple of online questions also.
You don't have those drones going up and down?
Not there yet. After the grant, perhaps.
One very specific question. How do we define trauma in the Indian context? The threshold or severity of trauma, is it different? Because the prevalence of PTSD is lower in the Indian context.
Prevalence of PTSD is not lower in India, number one. Okay, so that is, I don't know how that statement comes through, because the premise is inaccurate. PTSD is not less common in India. And so the trauma as defined is, so trauma literature itself has various things: natural trauma, social, civic, personal, etc., etc. Depending on whether it's a natural event like a cyclone or an earthquake, that obviously has to be the same for everyone. psychological or social trauma depends on how your proximity to civic unrest or, oppression, which in countries like India is semi-tolerated most of the time. So obviously trauma will be less because it is considered to be traumatized is normal.
Little bit like learned helplessness.
Exactly. So all these issues of trauma therefore need to be seen through that lens. For example, the most again, because one worked on it a bit more, take the Holocaust. Whatever, 500,000 people dead and about a couple of million in concentration camps. You can find at least 4 or 5 journal of Holocaust studies, and half of psychiatric thinkers, whether it's Jaspers or Eric Fromm, down to all the others, talk about the Holocaust. A similar event occurs with the partition. Not a single paper on it. Okay, because in the non-weird cultures, violence and oppression is such a fact of life that it is not given any great relevance. And it's like the joke about the air crash in Indonesia. Mr. Smith and 80 other Indonesians died. But Mr. Smith is Mr. Smith. Right. Everybody else is nameless mass.